This is by definition a multidisciplinary tumor board, where you're not just having one individual or discipline's perspective about head and neck cancer. You have the opportunity to have each patient's case reviewed by a surgeon, a radiation oncologist, medical oncologist, a pathologist, and a neuroradiologist who reviews everybody's case. We go through each component of that patient's care so that by the end of the discussion, you've had multiple second opinions. In this patient's case, I learned about an individual with an oral cavity squamous cell carcinoma. He was able to see me in consultation, but as soon as he stepped out of my office, I was already having a virtual discussion in meetings with his radiation oncologist.
We discussed the extent the tumor invaded towards midline in the oral tongue. I was wondering what the surgeons thought actually about the contralateral neck, so the uninvolved opposite side of the neck. The group gave their consensus that the contralateral side was actually not considered to be at a high risk, and with that, with the radiation volumes that I then went on to design, we were able to spare that area.
Many patients with head and neck cancer are treated with surgery. Myself as a robotic surgeon and some of my other robotic surgery colleagues often will care for patients with specific tools that we have at the medical center. And then subsequent to that treatment with their head and neck cancer, they can go back to the community cancer centers to receive their adjuvant radiation or chemotherapy. Almost as though we're just one hospital and one team that has been something that we haven't had before.
As much as things have been standardized through the National Comprehensive Cancer Network and ASCO and ASTRO, there are judgment calls with every case. Having a group of experts to bounce these sort of judgment calls off of it, I think, is one of the most valuable parts of the tumor board.
It's really created a much broader and more inclusive academic community. And when your physicians are talking more often, they trust each other, they reach out to each other more often, and patients have benefited from it.
Time and time again, it's been demonstrated that patients who are treated on clinical trial have superior clinical outcomes. We have numerous clinical trials open in the head and neck space, and we're opening more all the time.
We now have actually branched out some of our clinical trial programs to our satellite hospitals and our partners, where there are now clinical trial opportunities at Upper Chesapeake or Shore Regional or different system hospitals that may not have been there before. I'd say this program is a perfect example about how the University of Maryland Cancer Network is starting to mature, how we're starting to become colleagues more so than ever before. We've often been restricted by distance in the past, and now that those distance barriers have been removed, I think we're really starting to recognize we're all really colleagues under one single system, and our patients are able to be shepherded from doctor to doctor based on their needs seamlessly.